Yeah. So John, just again, you may have comments and questions for each other, but what aspect of telehealth is part of your program in Seattle?
Yes, I oversee all the strategy and QI operations for telehealth. So we've done random chart audits to make sure that it's being done responsibly, and make sure they're using the doc phrases, the document, everything, and dropping charges appropriately. In our clinic, we use telehealth primarily for follow-up, just because we feel like as a referral center, we're usually getting more of the complicated folks these days, whether they are co-infected or they have renal disease or cirrhosis and things like that. So we do like to have that first visit in person. We also have a fiber scan machine, and I think that is a real differentiator for us. We don't have a ton of fiber scan access around the state, but certainly follow-ups we do quite a bit, but that's worked out really well.
Mm-hmm. Do you have any questions or comments for Blair, John?
I was just interested if you are part of the University of Missouri Show Me Echo. Do you have folks that are in the Kansas City area that are participating?
Yeah, absolutely. And then, the person I mentioned that does a lot of hepatitis C treatment at the other FQHC, Rachel Melson, I know she's a regular participant. It happens to fall at a time where it's difficult for me to participate. So I've been a big participant and a lead member on the HIV echo, but I have not really been a major participant in the hepatitis C one. Though my understanding it's doing great work there.
Thank you.
And I'll just say, I wish we had a better access to FibroScan. That's an area we don't really have good access, and especially for our patients who are often not in the Kansas City area. So we find ourselves really relying on FIB4 primarily.
Got it. Which can work well. Very quickly, a new testing, point of care testing for virologic positivity was just licensed by the FDA. Do either one of you see that being integrated into your care facilities?
John,
John, go first.
Yeah, so we already have reflex testing. We've had reflex testing for antibody tests for over 10 years. But I think where they could be useful would be in like needle exchange or methadone treatment facilities and things like that. So I know one of our nonprofits in the area, the Hepatitis Education Project, that would be a good place to incorporate this kind of technology more in the community.
Thank you. Blair?
You're asking about the rapid Hep C RNA?
Yeah. Yes.
The Cepheid machine. Yeah. So we have a machine. We got one for COVID testing, so we wouldn't have to buy the machine. The question is whether we should invest in the cartridges and do that at our site. I haven't pulled the trigger on that for a couple of reasons. Most people come to us because they've had a rapid finger stick Hep C antibody test, and we do a lot of that in clinic. And so we've kind of already done that. We know we need to do the RNA. So we also want to do the Hep B testing on these patients. And we've actually found several cases of Hep B, and of course we want to check if they're immune, and then we need to do our labs for our FIB4. So we kind of need to do a blood draw on patients anyways. And then the Cepheid machine, I think people are probably aware of this. When they say rapid, they mean 60 minutes, right? So in terms of patient flow in the clinic and keeping someone sitting there for 60 minutes to get them the result, that is also something to kind of consider. I haven't looked through the reimbursement stuff in terms of buying the cartridges and actually getting reimbursed. That's always a big consideration for an FQHC. Can we actually sustain buying those expensive cartridges? The other thing is, it's a qualitative. I mean, correct me if I'm wrong. It's a qualitative test, not a quantitative test. I don't know that that's particularly meaningful because if it's, if it's positive, you're going to treat, So, but it's not, it's not the same as getting a blood draw.
Thank you. We did have one late arriving question about the role of genotyping for hepatitis C in clinical practice. Please comment, both of you, starting with Blair, then John.
Yeah, generally we're not doing it. We're really trying to, for two reasons, we're really trying to minimize the amount of blood we're drawing. We have very great difficulty actually getting blood out of patients in many cases. That could be a limiting factor for treatment, more than you might think. Just we can't get enough tubes, and just because of the poor venous access, and in general, it's not needed for treatment, so we're trying to minimize the expense. I know there's cases in which it would be advisable to have one, but we don't tend to encounter those very often in our broad-based treatment plans.
Thank you. John?
Yeah, we're similar as what Blair said. And I just wanted to point out that, the recent AASLD IDSA guidelines that say that genotyping is optional. I think the situations where I might want to get it would be if someone has, ongoing injection drug use or pretty recent, and in case they get reinfected. And sometimes you don't get that SVR12. You're not really totally clear if this was a failure or reinfection. But we don't want this to hold up the treatment. So if that's the last thing, and we don't have it, we just go ahead and treat them. Yeah, I do want to emphasize how expensive these are. At least in our lab, people are getting charged over $500 for it. So it's not a insignificant expense. And it's ironic that sometimes the most problematic issue for our patients is the actual cost of the labs and the workup. It's the treatment often can get covered through patient assistance or the various programs, but lab testing is not covered. So I think we need to be cognizant of that barrier for our patients.
Thank you very much. That's an excellent comment. These are pan-genotypic drugs, and the recommendations reflect that, and those are really good advice for clinical practice and the use of genotyping. So thank you very much. So I'm going to thank you all for your great presentation today, both to John and Blair, and by extension Elise and Cabell Jonas. So again, all of this content will be available on our website, globalhep.org.